ventricle, very important, one of the most beautiful anatomies that you're going to see besides cavernous sinus. What is the fourth ventricle? Well, it's the most inferior ventricle, and it's in the posterior fossa, and the approaches and the pathologies which are located here are especially for pediatric neurosurgery. This is important because if you know, if you're in a pediatric neurosurgical department, but also if you're operating on posterior fossa, this is something which you need to know. And you might wonder, okay, why am I using these very old, outdated drawings instead of the extremely cool new representations by Rotan? And that is because I want you to appreciate the beauty of the pioneers, of the beginnings of microsurgical anatomy, and that's 1982, that's also Rotan with Matsushima. But this is the first paper that actually, it's a very thick paper, and it deals with the microsurgical anatomy of the fourth ventricle, but also the posterior fossa and the cerebellum. And this is, you know, this is the first one. This is pioneering work. And what you're going to see is that the one that illustrated was they did such a beautiful job that once we've done with the slides where you see these, then you're going to look at anatomy and just say, hey, that's really how it is. And it's a bit easier to remember this sort of schematic drawings than if you've looked at Rotan. You see that even in his book, he has these very old drawings from his early articles. They're there because they were so important and so good that he actually decided to leave it there. So this is really important. This is really important that you know where it all began. And what I want to ask is, do you know the divisions of the vermis? And do you know the lobules that correspond to them? The divisions of the vermis is 100% subject in neuroanatomy that's taught here, that I know. And the lobules that correspond, that's something a bit more, yeah, that's more for neurosurgeons than for other people. But do you know them? Let's start on the suboccipital surface. There are two surfaces to the cerebellum, the Ventricle and the suboccipital. You most often see the suboccipital when you're opening here, posterior fossa. You also see centaureal surface if you're going supracerebellar to pineal region or Ventricle. And suboccipital surface, this diamond-shaped structure is the pyramid. And the uvula and the tonsils, ENT-like thing, tuber and the folium here above. So, lingula, that's on, you don't see lingula almost ever, unless you're doing supracerebellar approach and your patient has an enormous arachnoid cyst in the suprapineal cistern. Then you're going to see lingula, because it's on the back side attached to the collicular plate. So you're never seeing lingula. Then central lobe, and how's that, you know, what's that, what's the top of the vermis? What's that called? It has a name that's... Flavis? What's that, what's the top? It has a name that says top. Huh? No? It's called a culmen. And that's, you know, it has a name that says top. It's the top. That's why it's called a culmen, because it's on top. And then when you come down from the top, you also have a name that suggests you're going down from the top. And what's that? Declive. And so you have culmen, declive, and then you have folium, which is called a folium because it has a lot of foliae. And then the tuber, which looks like a tuber, a pyramid, which looks like a pyramid, a uvula, which looks like a uvula, and two tonsils that look like a tonsil. So the old anatomists that came up with this, they weren't totally crazy. They were thinking about something. So very important. If you're operating on a structure and you don't know where you are, that's irresponsible. Always know where you are. It's sometimes, I have to agree, it's sometimes very difficult when you're operating on glioblastoma to know which gyrus exactly you are, but you have to try your best to know every time you're on a structure, what it's called and what it's doing. Because otherwise, you're using your bipolar, you're sucking out collateral stone, but you don't know what you're doing because you don't know where you are. With cerebellum, it's the same. You're doing the cerebellum metastasis of a carcinoma of the breast, and you're going inside cerebellum. And I keep seeing this it's all around the world. It's in Germany. You know, corticotomy. Yeah, where? Corticotomy. Yeah. Have you done a corticotomy of the entire cerebellum? With corticotomy where? Or transsulcal approach. Yeah. Where? Did you use pyramidal fissure? What did you use? Anyway, this is the old. When you're looking at Rotan posterior fossa, this is the old and then anatomical description. This is the new description. Okay. So once you're opening, you see this. Pre-biventral of suboccipital fissure. Most important. This is once you've seen the cerebellum, suboccipital fissure. Once you see that big fissure, suboccipital fissure. Why is that so important? The pyramid sits on top of it, and the uvula. Suboccipital fissure, pyramid, uvula. You've identified your landmarks. You can operate. Now, once you've separated, so the fourth ventricle has a roof made of two parts, a floor, and two lateral recesses. The roof is made out of anterior and posterior parts, which converge at the fastigium on top. So you have to see it as it's actually positioned like this in a normal. This is anterior side of the roof, and this is posterior side of the roof, superior, inferior, however you want to call it. Here's floor. Okay, so the superior side of the roof is made out of the superior medullary velum, which connects the superior cerebellar peduncles, and this is white matter. This is fastigium here, and this inferior medullary velum, so posterior side, which connects. What does it connect? Do you know? Very important. Does archicerebellum tell you something? The oldest cerebellar. The archicerebellum is also called which lobe? Yes, flocculonodular. So the inferior medullary velum actually connects the nodule to the flocculus, making this whole complex the flocculonodular lobe. So this is the underside of the roof of the fourth, and then you have the floor, which we're going to see in a minute. So once you've come in between the tonsils, you see again uvula, pyramid, inferior medullary velum, lateral recess, and the tila choroidea. What is the tila choroidea? That's a double layer of arachnoid with choroidal arteries, which extends to the lateral recesses, but has three very important openings. It's not a continuous membrane. It has three openings. Which are the three openings? Yeah, right. Very good. Pushka and Yemi. So tila choroidea with the choroid plexus, flocculus, and once you're at flocculus, you know you're in CPN. So we've talked about this. Culmen, quadrangular lobule, declive, simple lobule, and then the folium, which sits as well on the tentorial as on the suboccipital surface with the superior semilineal lobule. And here, between the cerebellum forms on the in the baby, and it spreads around the brainstem. And as it spreads around the brainstem, as usual, it gives off three fissures. Cerebellar mesocephalic fissure here, V-shaped. The cerebellopontine fissure, which is also cerebellopontine angle, which is also V-shaped along the petrous side of the cerebellum, and the cerebellomedullary fissure, which is the most complex in the human anatomy. Again, the nodule and the inferior medullary velum, and the fastigium, where the two anterior and posterior sides of the roof converge. And what you also see here is the lateral recess, and middle cerebellar peduncle sits on the outside, and superior and inferior cerebellar peduncles are lining the inside. So if you're operating on these structures, then you're going from inside, and if you're operating on middle, you're going from CP angle. Fastigium again, this is just to see the underside of the fourth. And the tila choroidea, which has a T shape, so you have two of inverted L's, however you want to call it, two median sides and then lateral sides extending all the way to Luschka. And this is a very interesting structure, the rhomboid lip. This is actually just a neural structure which is like a cul-de-sac at the lateral recess, ending the lateral recess. Now very interesting is the floor of the fourth, obviously, but we're going to be talking about that when I show you a lateral. So again, when you see the dissections now, it's like, okay, I've seen it in the 1982 article, I can identify this immediately. Yeah, tentorial surface, culmen, primary fissure, and postclival fissure. This is very important when you're doing super-tent approach. Primary fissure, you know you're on the culmen. Very important, very deep. Quadrangular lobule, simple, superior semilunar, which is on the tentorial and suboccipital surface, on suboccipital surface, volume tubular pyramid. It's also loops from all surrounding tissue, uvula, and nodules and tonsils. So in between the tonsils, you're going to enter the fourth. If you're opening it from above, then you see the central lobule and the wings of the ala of the central lobule, and the lingula is there. The culmen is here, and if you're opening further, then you look inside, then you see the medial sulcus, superior peduncle, and you see the nodule with the inferior medullary velum extending towards the flocculus. The tila choroidea with the choroid plexus extend to the lateral recesses, and what you see is here, you can't see this very good here, I'm afraid. This is pica. This is pica making the loop above the tonsil, and that's why it's called the tilovilotonsillary segment, because it's tila choroidea, velum, inferior medullary velum, and tonsil. Tilovilotonsillary. That's where it comes from. Now, all these names are not made to well, when you read for the first time, it's meant to give you help. But when you think about it, the more you learn anatomy, you know that there's somebody who's actually thought about this at length. So again, inferior medullary velum, we've opened the lateral recess, we see the choroid plexus, 7th, 8th, and you'd see 9, 10, 11 coming here, ica, flocculus, and the rhomboid lip would be here to close the lateral recess. You can see the lingula now, so you never see this, huh? Unless your patient has a huge arachnoid cyst here, and then you can see it. Nodule, and fastigium is here, where superior medullary velum and inferior medullary velum come together, and the dentate nucleus, and that's very important, is exactly at the pole of the tonsil. So if you're doing a tonsillectomy for a patient with Chiari malformation, for instance, you have to know when to stop at the superior pole of the tonsil in order to not damage the dentate nucleus. And this is actually a beginning of the tilovelar approach, Mengendi, inferior medullary velum, tonsil. You're going to be splitting the two tonsils, and you won't split the vermis, because if you split the vermis, especially in children, your patient may get an ankylate mutism, cerebellar mutism, or posterior fossa syndrome. One of our pediatric neurologists, Dr. Katzmann, is doing, that's her area of interest, and she's doing a lot of research in that. But if you split this even further, you see here the rhomboid lip at the flocculus and the tilovelar junction, and if you open this up, you see the peduncle of the flocculus. Yes, the flocculus also has a peduncle, and the tinea, and the inferior peduncle. So peduncle of the flocculus and the inferior. And if you open it from the front, so you cut out a piece of the pons, then you see the fastigium here at the level where the roofs come together. The tila choroidea and the inferior medullary velum with the choroid plexus, and you see Luschka here, the opening in the tila choroidea, 8 and 7, the nodule and the inferior medullary velum extending from it, the inferior medullary velum. And once you've opened this up, you can also better see the choroid plexus in the lateral recess. And why is this important? Because if you have a medullosoma here, then it's very, very often going to extend all the way to the lateral recess to Luschka. And it's going to, you're going to have to follow it if you're aiming for a gross total resection, which is still the case. So this is just with the arteries, SCA, fourth ventricle, a superior peduncle, inferior peduncle, medial peduncle floor, nodule, inferior medullary velum, and the choroid plexus on the other side. Dentate nucleus, don't forget, the head of the tonsil here at flocculus, and the floor. It has a pontine junction and medullary part, so pontine extending all the way to cerebral aqueduct and junction between the two. And this is one of the most beautiful structures which you're ever going to come across in surgery. It's actually amazing. I'm sorry I don't have any movies for you today, but it's actually once you open this up and you dissect it here, and you've got the picas out of the way, and the 11th nerve is okay, and you come here and you see the median sulcus, and then you immediately see this, the hypoglossal triangle. So the median sulcus, it splits the floor of the fourth ventricle in two, and it's also a place where Lawton approached the cavernoma through the median sulcus. It's something we shouldn't really do, because there are a lot of structures here on the backside, but he decided that was safe enough, and I think it was in that case, because she had a deficit. And what you also see is you have this sulcus limitans, and the sulcus limitans, between the sulcus limitans and the median sulcus, you have the median eminence. And this is the median eminence, and that's in the intermediary zone facial colliculus. So that corresponds to the abducens nucleus, and not the facial nucleus as many people think. It corresponds to the abducens nucleus and the facial nerve, which travels from its nucleus peripheral. The peripheral nerve, which travels around the abducens nucleus. And we actually had a patient who had here a tumor, and where it was described as a central facial palsy, but it was actually a peripheral nerve palsy, because the peripheral facial nerve was not intact, and not what most of the people thought the facial nucleus. So you also see inferior peduncle, superior peduncle, medial peduncle. The sulcus limitans also has these indentations, the superior and inferior fovea. Superior corresponds to facial colliculus, inferior to the hypoglossal triangle, and around the hypoglossal triangle you also have the vagal triangle, and then the funiculus limitans, which separates it from the area postrema, and this is called the calum scriptorius. You know this. This is the audex. This is the inferior part of this extremely beautiful structure. And on the lateral side, you have the vestibular section and the dorsal-cochlear nucleus. So, again, just a view of the dentate tubercle, where the dentate nucleus is coming very close to the roof, and the inferior medullary velum and the head of the tonsil. This is something you have to keep in mind when you're operating. Tilo-velar approach, very beautiful. So you look at suboccipital surface, and you know, suboccipital fissure, pyramid, uvula tonsils, you may operate. You're splitting the tonsils, then you're going to split the tila. You see the T-shape with the choroid plexus, uvula, nodule, inferior medullary velum extending all the way to Luschka, but you see again the pica running across the head of the tonsil. You're going to hear that probably in the next presentation. And when you're looking at when you're doing a short review of fourth ventricle anatomy, you see that there are not very many reports on the actual anatomy. But two important reports on the endoscopic anatomy. You see here tila, choroid plexus, facial colliculus, and the abex here with Jande, and again the colliculi. So this is all endoscopic anatomy, but even more beautifully, the tilovelar approach endoscopic, also by Italians because they're a bit crazy about endoscopy. And tonsils, and once you go in, you see obviously choroid plexus, and this is again the floor of the fourth ventricle, median sulcus, and obviously calamus scriptorius, area postrema. And I just want to, as an end, I just want to say, read as much anatomical reports as you can. And this is an excellent article by Rotan and his team from last year, 2014. 3D microsurgical anatomy of the safe entry zones to the brainstem. And they actually did amazing dissections. You can see here, lateral mesencephalic sulcus, third nerve, nucleus, and they actually dissected all the fibers and the nuclei in the brainstem. It's actually something you will very rarely see. So it ties to this and to the Calazia. Just read a lot of anatomy and come to the Rotterdam Skull Base course if you want to. Thanks.